Hello and welcome to ClinMed Compass. Today, we are going to be looking at the topic Hepatic Encephalopathy. This is a follow-up from the last session on acute hepatic failure. In this focus session, we will walk you through the essential facts, clinical pairs, and practical approaches you need to recognize, evaluate, and manage hepatic encephalopathy effectively in clinical practice. Before we begin, please subscribe to our channel, ClinMed Compass, and turn on the notification bell so you are updated on future quick review lectures and internal medicine essentials. Grab your notepad and let us get started with the key points in hepatic encephalopathy. Before we begin, let us assess our baseline knowledge with a quick pre-test quiz. Question 1. Which of the following is the primary neurotoxin implicated in the pathogenesis of hepatic encephalopathy? Bilirubin, ammonia, urea, creatinine. Question 2. Which of the following is not a common precipitating factor for hepatic encephalopathy? Gastrointestinal bleeding, infection, high protein diets, hypothyroidism. Question 3. A classic EEG finding in hepatic encephalopathy is burst suppression, triphasic waves, delta waves, epileptiform discharges. We are going to revisit these questions at the end of this lecture. Now, let us start with the definition. Hepatic encephalopathy is a potentially reversible neuropsychiatric syndrome that results from liver dysfunction or from portosystemic shunting. Key features include accumulation of gut-derived neurotoxin, mainly ammonia, a spectrum of brain dysfunction from subtle cognitive changes to deep coma, and a variety of neuropsychiatry and motor symptoms. Hepatic encephalopathy is classified in various ways. Most important is the etiological classification into type A, type B, and type C. Type A is that which is associated with acute liver failure. Type B is that which is due to portosystemic bypass without intrinsic liver disease. And type C is that is associated with cirrhosis and portal hypertension or shunting. Type C could also be further classified based on the clinical cause. We have episodic, persistent, and minimal. For episodic, they have clear precipitants with intermittent episodes of symptoms. For persistent, they have chronic and continuous symptoms. For minimum, they could be detected only through specialized tests. In other words, there are no obvious neurological features in minimal hepatic encephalopathy. From the cognitive standpoint, hepatic encephalopathy is classified as covert and overt hepatic encephalopathy. For covert, they have minimal or no symptom and is equivalent to West Haven grading of 0 to 1. For overt hepatic encephalopathy, these ones have clear clinical signs equivalent to grades 2 to 4 West Haven grading of hepatic encephalopathy. The central concept in hepatic encephalopathy is accumulation of gut-derived neurotoxins. These toxins bypass liver metabolism due to liver failure or portosystemic shunting. They enter the systemic circulation, then they cross the blood-brain barrier. Within the CNS, they are taken up by astrocyte and they disrupt astrocyte function. This leads to cerebral edema and neurologic symptoms. These changes that occur in the astrocyte are the histologic hallmark of hepatic encephalopathy, and this is referred to as Alzheimer's type 2 astrocytosis. Ammonia is the primary neurotoxin involved in hepatic encephalopathy. It is produced by urease-producing gut bacteria from protein breakdown. Normally, in a healthy liver, ammonia is converted to urea and excreted. However, in liver dysfunction, it bypasses the liver metabolism, enters the systemic circulation, and reaches the brain. In the brain, it is taken up by astrocyte, where it combines with glutamate to form glutamine. The combination of ammonia and glutamate forms glutamine, catalyzed by glutamine synthesis. This causes the astrocyte to swell, known as Alzheimer's type 2 astrocytosis, leading to cerebral edema. The CNS effect of ammonia could be summarized as 1. Reduced excitatory neurotransmission due to the low glutamate. Swollen astrocytes, which causes cerebral edema, and characteristic Alzheimer's type 2 astrocytosis, which is the hallmark of hepatic encephalopathy. Here's a histologic image of Alzheimer's type 2 astrocytosis. These are normal astrocytes, as you can see, labeled as N, normal astrocytes. These are abnormal astrocytes, labeled as ALZ. The astrocytes are pale and they have swollen nuclei. This microscopic hallmark reflects astrocyte dysfunction and cerebral edema in hepatic encephalopathy. This infographic explains the role of ammonia in the pathogenesis of hepatic encephalopathy. It starts with the production of ammonia in the gastrointestinal tract by urease-producing bacteria from protein metabolism. Under physiological conditions, the liver efficiently detoxifies ammonia, converting it to urea through the urea cycle and excreted via the kidneys. However, in the setting of liver dysfunction, this detoxification is impaired. Ammonia enters the systemic circulation by passing hepatic clearance. Circulating ammonia readily crosses the blood-brain barrier, gaining access to the central nervous system. Within the brain, astrocytes take up the excess ammonia as part of a protective mechanism. Ammonia combines with glutamate in the astrocyte to form glutamine, catalyzed by the enzyme glutamine synthesis. Accumulation of glutamine within the astrocytes creates an osmotic imbalance, leading to cellular swelling. The resultant astrocyte swelling contributes to cerebral edema and elevated intracranial pressure. Histologically, this condition manifests as Alzheimer's type 2 astrocytosis, a hallmark of hepatic encephalopathy. Hepatic encephalopathy is not only about ammonia. Systemic inflammation also plays a role. Infections or endotoxemia lead to cytokine release, which increases blood-brain barrier permeability. This allows ammonia and other gut-derived neurotoxins, such as phenol, mercaptans, short and medium-chain fatty acids, to accumulate within the CNS. This favors entry of aromatic amino acids over the branched-chain amino acids. This imbalance in favor of the aromatic amino acid leads to the synthesis of false neurotransmitters like octopamine, tyramine, phenylethanolamine. It increased GABAergic tone, causing CNS depression and disruption of key neurotransmitters such as dopamine, glutamate, and noradrenaline. Other factors contributing to hepatic encephalopathy include manganese deposition. Manganese accumulates in the globus pallidus, causing Parkinsonism. Zinc deficiency. Zinc deficiency impairs the urea cycle and ammonia clearance. Reduced cerebral blood flow. This decreases oxygen and glucose utilization, contributing to global brain dysfunction, thereby worsening hepatic encephalopathy. Understanding what precipitates hepatic encephalopathy is vital for management. Key precipitants include increased nitrogen load, such as gastrointestinal bleeding, constipation, high protein diet, and azotemia. Electrolyte imbalances, particularly hypokalemia and hyponatremia. Medications such as sedatives, opioids, benzodiazepines, and even diuretics can precipitate hepatic encephalopathy. Infections like spontaneous bacterial peritonitis, urinary tract infections, and pneumonia. Dehydration due to vomiting, diarrhea, or large volume abdominal parasitensis. Diuretics also would cause dehydration. Other precipitants include transjugular intrahepatic photosystemic shunts, hepatocellular carcinoma. Hepatic encephalopathy can present covertly or overtly. So we'll look at the clinical features in that respect. Covert hepatic encephalopathy is also called minimal or subclinical hepatic encephalopathy. They have no obvious clinical signs, but it affects cognition and psychomotor performance, such as attention deficits, memory lapses, and impaired performance at work. These subtle changes are detected only through psychometric or neurophysiological testing, like the number connection tests. This is the number connection test. Patients are asked to connect a series of numbers in ascending order as quickly as possible. It assesses attention, visual scanning, and psychomotor speed. The block design test, here patients replicate geometric patterns using colored blocks. It assesses visuospatial and constructional skills. Now we'll look at the overt hepatic encephalopathy. Overt hepatic encephalopathy shows clear and progressive clinical signs, from general features like nausea, vomiting, and weakness, neuropsychiatric manifestations, confusion, irritability, sleep-wake reversal, disorientation, stupor, then down to coma. Cognitive decline, as in failure in tasks such as the serial 7s or the trail-making tests. Motor signs such as flapping tremor or hysterexis, constructional apraxia, for example, inability to draw a 5-pointed star, gait disturbances, dysarthria, neurologic signs such as spasticity, hyperreflexia, and flexor plantar responses. Other clinical features include fetor hepaticus. This is a musty or sweet odor on the breath due to volatile amines. They will also present with signs of chronic liver disease, such as jaundice, palmar erythema, caput medusae, testicular atrophy, ascites, and others. This slide shows an image of a patient with outstretched arms and wrist dorsiflex, representing flapping tremor or hysterexis. While the next picture there shows constructional apraxia, patients with hepatic encephalopathy may struggle to perform tasks like drawing a simple star or connecting lines. This reflects visuospatial and motor planning deficits. This is the West Haven grading of hepatic encephalopathy. This grading system categorizes hepatic encephalopathy into grade 0 down to grade 4. The parameters include the mental status, hysterexis present or not, and EEG findings. 0 is subclinical or the minimal hepatic encephalopathy, where there are no obvious clinical features, but can be detected via specialized tests. Grade 1, they have mild confusion, reversal in sleep pattern. Grade 2, moderate confusion, inappropriate behavior. They become drowsy, but they are easily rousable. In grade 3, they have marked confusion, that disoriented, they are stuporous. And in grade 4, they are comatose. however initially responsive to pain, but later unresponsive. You have hysteresis, typically from grade 2 and 3. Then the EEG becomes abnormal from grade 2, 3 down to 4. Differential diagnosis. When evaluating a patient with hepatic encephalopathy, always consider other causes of altered mental status, from metabolic, infectious down to structural issues. Metabolic differentials, hypoglycemia, DKA, uremia. Nutritional, Wernicke's encephalopathy, infectious, meningitis, encephalitis, brain abscess, toxicologic, alcohol, intoxication or withdrawal, drug toxicity, opioids, sedatives, carbon monoxide poisoning, vascular issues such as stroke, both ischemic or hemorrhagic, cerebral venous thrombosis, structural or neoplastic, brain tumor, subdural hematoma, or even brain abscess is also in this category. Diagnostic evaluation. We'll look at some of the laboratory investigation we can do in patients with hepatic encephalopathy. We'll start with the liver function test. In liver function test, we'll have elevated bilirubin, reduced albumin, and increased or prolonged prothrombin or INR. For the liver enzymes, AST and ALT, they may be normal or low in advanced disease due to hepatocyte loss. However, if the encephalopathy is from acute hepatic failure, the enzymes will be elevated. For serum ammonia, it's often elevated, but levels don't always correlate with clinical severity. Other important investigations that may be done include the complete blood count. Look out for anemia in case of bleeding, leukocytosis in case of infection, thrombocytopenia in case of hypersplenism. You want to assess the renal function test, blood urea nitrogen and creatinine. Electrolytes are also important for hypokalemia or hyponatremia. Blood glucose for hypoglycemia. Blood or urine cultures if infection is suspected. You want to assess for viral markers for that is BC. Also, autoimmune markers are also important to search for etiology. Antinuclear antibody, anti-smooth muscle antibody, anti-mitochondrial antibody, as the case may be. Imaging studies are key in diagnostic evaluation of hepatic encephalopathy. You may want to do ultrasound scan with Doppler. This assesses the liver architecture, also assesses for ascites or portal hypertension. The CT or MRI of the abdomen helps to look out for liver masses such as hepatocellular carcinoma or even portal vein thrombosis. The CT or MRI of the brain can check for stroke or intracranial space occupying lesions. It is important to say that the MRI of the brain may reveal T1 hyperintensity in the basal ganglia. This is suggestive of manganese deposition. The EEG findings include triphasic waves. This is sensitive but not specific. Delta waves in EEG is seen in grade 4 hepatic encephalopathy. The lumbar puncture for CSF analysis is rarely abnormal, but may show elevated protein or gamma aminobutyric acid levels. To diagnose covert hepatic encephalopathy, we rely on specialized cognitive testing. These tools are sensitive and can detect subtle neuropsychiatric deficits before overt symptoms may appear. Let's briefly go through some of them. One is the number connection test. Patients are asked to connect a series of numbers in ascending order as quickly as possible. The digit symbol test. Patients match numbers to symbols using a given key. The block design test. Patients replicate geometric patterns using colored blocks. Other tests include the stroke test, the trail making test, the critical flicker frequency, and inhibitory control tests. Together, these tests form the cornerstone of early detection of hepatic encephalopathy in patients who may appear normal on clinical examination but at risk of cognitive impairment from hepatic encephalopathy. Now let's talk about the management of hepatic encephalopathy. First, we discuss the principles of management. The goals are to provide supportive care, to identify and treat precipitating factors, to reduce ammonia and gut nitrogen load, to offer nutritional support, to manage the underlying liver disease, and consider liver transplantation for refractory or recurrent cases. Supportive care is crucial, especially in grade 3 and 4 hepatic encephalopathy. You admit to ICU, ensure airway protection and avoid sedatives, manage cerebral edema, correct electrolyte imbalances, prevent infection and aspiration, treat coagulopathy if present, use vitamin K or fresh frozen plasma as needed. Reduction of ammonia load. The first-line agent for reducing ammonia is lactulose. At a dose of 10 to 30 ml orally or rectally, titrated to 2 to 3 soft stools per day. How does lactulose work? It acidifies colonic content, converts ammonia to ammonium, which is trapped in the colon and excreted. It also acts as an osmotic purgative. An alternative to lactulose is lactitol, which is another non-absorbable disaccharide. Antibiotics are also used to reduce ammonia load. Rifaximin is the preferred antibiotic for hepatic encephalopathy management. It is broad-spectrum, non-absorbable, and well-tolerated. It reduces ammonia-producing gut flora. The dose is 500 mg twice daily. It's often used with lactulose for synergy and recurrence prevention. It has fewer side effects compared to older agents. Other options include neomycin. Neomycin alters gut flora. It is autotoxic and nephrotoxic, and it's less preferred. Another antibiotic is metronidazole, which is also occasionally used. In long-term use, it causes neurotoxicity. Nutritional therapy is key in management. Avoid prolonged protein restriction. Recommended dose is 1 to 1.2 grams per kg per day. Plant proteins and dairy proteins are preferred. Zinc supplementation is also important, especially in those that are zinc deficient, as it supports the urea cycle. Use branched-chain amino acid if the patient is intolerant to normal protein. Other therapy options include LOLA, L-ornithine, L-aspartate. This boosts the urea cycle, promoting ammonia detoxification. Sodium benzoate or phenyl acetate or phenylbutyrate, they serve as ammonia scavengers and they are aimed at metabolic removal of ammonia. L-carnitine supports mitochondrial function and also ammonia clearance. Flumazenil is a benzodiazepine antagonist that may help in cases of benzodiazepine-induced hepatic encephalopathy. Other emerging therapies include the use of probiotics such as lactobacillus and enterococcus. They help restore a healthy gut flora and reduce ammonia production. The molecular adsorbent recirculating system, MAS, it's a form of liver dialysis that removes albumin-bound toxins like ammonia, bile acids, bilirubin, copper, and phenols. MAS serves as a bridge to transplant or recovery in critical cases. Liver transplantation is the definitive treatment for recurrent or refractory hepatic encephalopathy, especially considered for those with poor quality of life and advanced cirrhosis. In most cases, hepatic encephalopathy resolves after transplantation, making it a curative option for suitable candidates. Prevention and recurrence control. To prevent recurrence, educate both patients and caregivers to recognize early signs of hepatic encephalopathy. Proactively address common triggers like constipation, infections, medications, and others. Consider long-term rifaximin prophylaxis in recurrent cases. Ensure multidisciplinary coordination. Hepatologists, nurses, dietitians, pharmacists, and social workers all play a role in the management of hepatic encephalopathy. Prognosis varies with liver function and the grade of hepatic encephalopathy. Type A hepatic encephalopathy, which is from acute liver failure, carries a poor prognosis. After first episode of overt hepatic encephalopathy, 1 year survival is around 40 to 50%. In severe cases, that is grade 3 and grade 4 hepatic encephalopathy, mortality without transplant can reach up to 70%. Post-transplant survival rates are excellent. 1 year, about 90% survivor, 5 years, 62%, and 10 years, 51%. Let's look at some novel therapies that are still being researched. You have the fecal microbiota transplantation, targeted probiotics, recombinant human arginase, agent that enhance gut barrier function or reduce inflammation, then GABA receptor modulators. Biomarkers are also being developed to aid diagnosis and monitoring. You have blood markers using proteomics and metabolomics, breath and salivary test analyzers, point-of-care tools to guide early diagnosis, monitoring, and transplant timing. Let's take a look at this case. At the end of the lecture, you will provide answers to this case in the comment section. A 60-year-old man with cirrhosis presents with upper gastrointestinal bleeding, somnolence, and asterexis. The question before us is, what is the grade of hepatic encephalopathy? Identify the precipitating factor and suggest initial steps in management of this patient. Kindly provide the answers in the comment section. To wrap up this presentation, let us note some key points. Hepatic encephalopathy is reversible with timely treatment. Always identify and treat precipitating factors. Lactulose is first line, and rifaximin helps prevent recurrence. Monitor for complications like cerebral edema and aspiration. Consider transplantation in eligible patients with refractory hepatic encephalopathy. Now let us revisit our pre-test quiz. Question 1. Which of the following is the primary neurotoxin implicated in the pathogenesis of hepatic encephalopathy? The correct answer there is ammonia. Question 2. Which of the following is not a common precipitating factor for hepatic encephalopathy? The correct answer there is hypothyroidism. Question 3. The classic EEG finding in hepatic encephalopathy is, the correct answer is triphasic waves, even though delta waves can occur in grade 4 hepatic encephalopathy. If you answered all 3 correctly, well done. If not, now you know why.
That brings us to the end of this key point review on hepatic encephalopathy. I hope you now feel more confident in identifying its features, recognizing common triggers, and applying the essential principles of management and diagnosis in your clinical setting. If this video helped you, give it a thumbs up, subscribe to our channel ClinMed Compass, and turn on the notifications so you won't miss our upcoming concise lectures and exam-focused reviews. Keep revising, stay curious, and remember, mastering the clinical essentials today builds your confidence for tomorrow. Thank you for watching.